going to be the Aryeh Shander Lecture by Dr. Christopher Simutowe. And his lecture is entitled Making the Case for Bloodless Surgery Programs in Developing Countries. Um, I should say a few words about the Aryeh Shander Lecture. It's been a feature of these meetings since 2019. I'm sure Aryeh, who I know very well, is very happy that this is not a memorial lecture. Uh, and the first lecture was delivered by the man himself, Dr. Aryeh Shander, in 2019, who's been an active member of the society and one of the foremost contemporary bloodless medicine practitioners at Englewood Hospital, where he and others founded literally one of the world's great programs. So, the aim of this lecture is to encourage the improvement of clinical outcomes and protection of patients' rights through the promotion of the science and practice of bloodless medicine and surgery. And the lecturer is always a person with a track record of outstanding academic contributions. I'm going to give a very brief introduction of Dr. Simutowe, and I hope I pronounced his name correctly. He's a consultant surgeon at Luanshya Mine Hospital in Zambia, and he has a distinguished career as a surgeon, having been a member now of the Royal College of Surgeons of Ireland and Edinburgh. So he's spanned the British Isles there, and he's had many positions involved in taking care of a variety of different surgical patients, even including obstetrics and gynecology. And his commitment to education and to teaching is well documented. He's currently a consultant surgeon in Zambia, where he manages a wider variety of surgical conditions for the mine's employees and registered members. And he's been providing bloodless medicine and surgery service since 1989, before some of our members were born. So I will welcome him and let him share his screen.
Thank you very much for those kind words. I will share my screen. So, making a case for bloodless surgery in developing countries. As an introduction, being a surgeon, just a brief on surgery and a bit of anatomy. So, surgery involves removing, repairing, or diagnosing a part of the human body. Hence, surgical procedures often result in blood loss, necessitating sometimes blood transfusions, especially in major surgeries. A bit about anatomy to understand why there is bleeding during surgery. The blood circulation system delivers the nutrients and oxygen to all cells in the body. It consists of the heart and the blood vessels running through the entire body. The arteries carry blood away from the heart, and the veins carry it back to the heart. The smallest arteries, vessels called arterioles, further branch into tiny capillaries where nutrients and wastes are exchanged, then combine with other vessels to exit the capillaries to form small venules. They are small blood vessels which carry blood to a vein and larger blood vessels that return the blood to the heart. So therefore, in surgical procedures, there is always some bleeding. So the art of surgery involves making a cut through the skin into the tissues to reach the diseased part. This is always accompanied with some bleeding, as some capillaries and veins are also cut. Blood transfusion, a lifesaver with risks. The history of blood transfusion dates back to the 1600s and the human-to-human transfusions in the 1800s. There has been a lot of developments and advancements in blood transfusions to make blood transfusion safe. And these are well documented. But we find that even with advanced technologies, we still see some complications attributed to blood transfusions. And these are like transfusion-related acute lung injury, like the allergic reactions, and transfusion-associated circulatory overload. And sometimes we see febrile non-hemolytic reactions and also the complications of infections. Every transfusion interferes with the recipient's immune system. So that's the well-documented fact. So every transfusion interferes with the recipient's immune system. And then there is this increased risk of infection. So a number of experts have been working around the clock, including the past speaker, who have been working around to see how do we improve this. And they came up with the term patient blood management, which was presented to the World Health Organization with evidence. And it has been supported highly and recommended by the World Health Organization in their whole policy brief of 2021. What is patient blood management? This is a patient-centered, systematic, evidence-based approach to improve patient outcomes by managing and preserving the patient's own blood while promoting patient safety and empowerment. The definition emphasizes the critical role of informed choice. Patient blood management involves the timely, multidisciplinary application of evidence-based medical and surgical concepts. And these are aimed at 1, screening for, diagnosing, and appropriately treating anemia. 2, minimizing surgical, procedural, and iatrogenic blood losses and managing coagulopathic bleeding throughout the care. And 3rd, supporting the patient while appropriate treatment is initiated. This World Health Organization policy brief really calls for urgent need to implement patient blood management. It raises the importance of managing anemia and in many instances, blood loss and coagulopathy, because taken together, these conditions represent one of the world's biggest, largely preventable, yet greatly underestimated public health and health economic burdens. The policy brief itself highlights the wins with patient blood management, and these are: 1, significantly improve global population health and the clinical outcomes of hundreds of millions of surgical, medical, and obstetric patients. 2, to reduce healthcare costs. 3, to improve patient safety. 4, to advance patient education and empowerment. 5, significantly reduce the demand for allogenic blood components and thus the national dependency on transfusions. The 6th one, to mitigate some of the resource constraints in healthcare, particularly for low-income countries and the low-middle-income countries. While trying to preserve the patient's own blood, there is this topic coming up of blood health. Knowing it and understanding blood as an organ is very important. So blood health is the optimal function of individual elements of blood and their associated interactions with all the organs and the organ systems. So PBM is a patient-centered, evidence-based approach to preserve the patient's own blood, to preserve the patient's own blood and improve the outcomes. In patient blood management, we talk about three main pillars. And there's one, two. The first pillar is screening for anemia and appropriate treatment. The second pillar is minimizing blood loss during procedures and managing coagulopathy. The third one is supporting the patient with timely elements. Anemia is very common in the developing countries. So just a bit on anemia. We see that anemia constitutes a public health problem in developing countries. The underlying causes of anemia are many, varied, largely preventable, and these include nutritional deficiencies, infectious, and hemoglobinopathies. Globally, it is estimated that in 2019, 40% of all children aged between 6 and 59 months, and 37% of pregnant women, and 30% of women 15 to 49 years of age were affected by anemia. The World Health Organization African region and the World Health Organization Southeast Asian region are the regions most affected. It is estimated that nearly 1/4 of the world's population of 1.8 billion people suffered some form of anemia. So we can see that anemia is quite key, and something must be done to improve it. Bloodless surgery. Just an overview. This is the provision of quality surgical care without allogenic blood transfusions. And it focuses on patient rights and clinical outcomes and safety. And it follows the patient blood management principles and the pillars. And we'll discuss more on the pillars. The challenges that we face in the developing countries are many. We see that in the developing countries, the hospitals are located both in the rural communities and in the cities. The hospitals in the rural communities tend to have less equipment, tend to have more general doctors than specialists, and more specialists we found in the bigger hospitals in the cities. But you'll find that even in the bigger hospitals in the cities, not all of them have necessary equipment. Hence, blood transfusions are common in major hospitals. Some of the major operations where you find that there is a lot of bleeding are cesarean sections, hysterectomies, and laparotomies for intestinal obstruction, operations on the thyroid gland, and also in trauma surgery. So there's a high blood loss in surgeries. Anemia is common, leading to even more need for transfusions, and also there's inadequate medical equipment. So there is need for bloodless surgery in developing countries. This will help to reduce the risks and the complications and infections which occur. And also, it aligns quite well with the World Health Organization patient safety and outcome improvement goals. The Global Patient Safety Action Plan for 2021 and 2030 reads, the goal is to achieve the maximum possible reduction in avoidable harm due to unsafe healthcare globally, envisioning a world in which no one is harmed in healthcare and every patient receives safe and respectful care every time, everywhere. There are a lot of programs taking place at present worldwide, which are there to provide bloodless programs. And there are more than 250 programs worldwide, and they are named differently. Some are just named the bloodless surgical programs. Some are patient blood management programs. Others are transfusion-free medicine programs. So there are these programs in a number of hospitals already which are working, but most of these are actually in developed countries. We go back to the pillars of patient blood management. They are the three: one, to optimize the hematocrit; second, to minimize blood loss; and third, to support patient tolerance of anemia. In bloodless surgery, sometimes we actually add the fourth pillar. So the first one, to optimize the hematocrit; second, minimize blood loss; third, optimize tissue oxygenation; and fourth, support physiological tolerance of anemia. A bit more on these. The first one, optimizing the hematocrit. We go back to the history. As I said, anemia is very common, so it's very important getting a very complete history. When anemia is found, it must be treated. Initially, one can start with just oral iron therapy, where if someone still has time before the operation to be done, or if you want to bring up the hemoglobin very fast, you can use parenteral iron therapy with adjuncts of vitamin C, folic acid, and vitamin B12. It is very important to continue providing nutritional support. And then the erythropoietin is key also in helping to increase the hemoglobin faster. The second pillar in minimizing blood loss, you still go back to history, make a good diagnosis. And when the patient is in hospital, we avoid the frequent phlebotomies so that we don't reduce the blood. Okay. What is key is also tranexamic acid in most of the surgeries that were used. And with a good team of the anesthetists and others, one can be able to do a good operation in most of things. Meticulous hemostasis and using a tourniquet, that is key. The technique that we want to use in theater is very important. Some countries are now coming across to have a cell salvage, which is key for reinfusion in terms where there's more blood loss taking place. After the surgery, it is important to still maintain the patients. So volume replacement is key so that there is enough blood circulating around. And where the hemoglobin becomes a bit low, oxygen therapy can be given as well. It is important to avoid the patient being restless, because being restless or being in severe pain can actually increase the need for oxygen and also make the patient's condition quite bad. So it's important to always give oxygen. Important to manage the patient's pain management is very key. Okay? Where someone's blood pressure is low, they might need to give inotropic drugs as well. Continuing with managing the patient post-surgery, we need to institute measures to make sure that the blood pressure is stable. So the support of always giving IV fluids and starting the nutrition early, that is good. Okay. The point of care testing, I think in some developing countries, we're able to have this just for checking HB, not a whole full blood count. Just for checking HB, just a small drop of blood that one is needed, and one can actually check the hemoglobin. So this is an area also post-op, the patient needs to be managed adequately to make sure that there is no complication. So how are we doing in the developing countries? Well, in Nigeria, I think the University of Calabar has a well-established bloodless program. So I thought we could use them as an example of how their program is doing very well, bring out improved clinical outcomes and reducing the need for blood transfusion. So there are two cases that I'll present, like this from the Calabar. this patient who's 42 years old, who presented with an 11-year history of a painless swelling in the anterior neck swelling and was breathless. And she traveled 200 kilometers to reach this facility. You can see that the need for having bloodless programs will quite spread so that the patient don't need to travel so long distances. So she had this neck mass, and which also affected the breathing of the patient because there was a stridor and a tracheal deviation. And the diagnosis on ultrasound showed that actually she had a multicystic multiple nodular. So she was prepared for operation. So the surgical team made a plan. Okay, the plan was to initially bring up the HB, which was low, and then plan for a bloodless subtotal thyroidectomy. And they used tranexamic acid to reduce the bleeding. And there was meticulous intraoperative blood conservation techniques. So here you find it is important for the operating surgeons to know the anatomy of the organ where they are operating. They should know where the blood vessels are, so that when they are doing an operation, there is less bleeding if they know what they are doing. Okay. This is the continuation of the operation. Meticulous surgery, knowing where the bleeding is, and then you do a good operation, bloodless operation. Earlier on, I said you find that in the countryside, we have general doctors who are not specialists, and they would tend to do a lot of operations, like cesarean sections. When they're operating, they might not be aware of where blood vessels are, and as a result, patients bleed a lot. And these are the areas where you find that they need more blood transfusion. So intraoperative on this patient, they gave tranexamic acid, which is very, very important. And this patient recovered quite well. And HB from 11 came to just 10.3, and the follow-up was quite well. The second one was an emergency. It's a female who after delivery, had vaginal bleeding for 1 hour. Okay. So that was bleeding for 1 hour, leading to active labor. Both fetuses were delivered, but one was stillborn, the cord prolapse, and others died. So there was severe obstetric hemorrhage with blood loss exceeding 2,000. That's 2 liters. That's a lot. The patient refused the blood transfusion. The patient was resuscitated with IV fluids. The hemorrhage management, they gave oxytocin, they gave tranexamic acid and uterine massage. But you find that even despite what was given, the bleeding continued. And the patient, his HB came very low to 3.3. And then the decision was made to actually take the patient to theater. And they found an atonic uterus with a lot of leiomyoma, so fibroid uterus. So a hysterectomy was performed, so removing the whole uterus, and she lost a lot of blood. We were probably at almost 4 liters. Total blood volume is 5 liters. That was quite bad. The patient was extubated, transferred to ICU. Look at the HB, it came to 1.8, but this patient was well resuscitated with IV fluids, antibiotics, and oxygen therapy. Okay. There were even some seizures, but the patient still recovered from that. He was given iron dextran and erythropoietin. The outcome was that the patient was eventually discharged from hospital with HB of 6.9 at the full recovery. So this was a successful bloodless management of severe obstetric hemorrhage in a resource-limited setting. With a good team, it is possible to achieve. Okay. So bloodless surgery is essential in improving patient safety in developing countries. So collaboration is needed to scale up such programs. Okay. So with this collaboration, others can be taught how to make these multi-committee programs. And then the focus really is on patient rights and clinical outcomes. So it is possible to have bloodless programs in developing countries, and it can help to achieve the goals that the World Health Organization and all the member countries have actually implemented and want to achieve. Thank you very much.